Three other speakers in this group to join us. Scott, I'm going to put you on the line a little because you're up here. Mrs. Jones comes to see you. You know she needs a Nissen, but you can't sell her on that. But she likes some of this other new fancy stuff. How do you decide what you're going to do, thinking that maybe in a couple of years you can convince her when she really needs the Nissen, if this fails, that she can have it?
Right. Well, very good question. And as you look at all this data, everyone should say, well, how do I fit this as an algorithm in my practice? And I think that that's a good question. I think the thing to do is to be honest with the patients, and you can tell them what the data is. First of all, we need to select patients who have normal anatomy and abnormal physiology, that they have symptomatic reflux. At that point, the options for therapy include Nissen fundoplication with the attendant risk of surgery and the disability that's associated with that and the side effects, but nonetheless very good results. Alternatively, we can offer them endoluminal therapy that we can, and I tell my patients, I think that this will be good for you 65 to 75% of the time. People are going to have excellent to good results. It's safe. It's relatively minimally invasive. And if it doesn't work, you have alternate therapies that can be taken in advance. This morning's program also demonstrated several series of Nissen fundoplication following transoral incisionless fundoplication that demonstrated pretty good results and similar results to open operation. So Mrs. Jones, here are your choices. 75% of the time you can have an outpatient endoscopic procedure, and I think you'll do pretty well. But there's a 25% failure rate. And if that doesn't work after a few months, you can still have a Nissen. And I think if you have that frank discussion, the response from patients includes, no chance do I want a 25% failure rate, give me a big operation, doc. And other ones say, hey, do as little as you can. And so I think that's a discussion you have to have.
Are there any questions from the audience?
Two questions. The first question is a patient selection for Strata, and if you have a large hiatal defect, do you not offer at that point? And the other question I have is for colonic anastomotic leaks. Today, can you conceive of a clinical scenario? Would you be willing to stent that rather than divert?
I'll just answer the Strata question. So large anatomic defects, I'm not interested in treating endoscopically. I think that those are large anatomic derangements that won't work. Strata can be used in a variety of settings with mechanical abnormalities, including following a failed Nissen or recurrent symptoms after Nissen. And we're learning more and more about it all the time. So I'm not unhappy using that. And I would say the same for esophagus.
Brent?
Somebody else talk about colons.
For acute colonic anastomotic leaks, the standard is to divert it and do a ileostomy. But I think in certain patients that have minimal contamination and are systemically stable, that I've been looking for those sort of patients that are willing to try that. And I think it's going to be a good option, but I don't have any data yet.
How about in the middle here?
Question about endoluminal therapies for reflux. My practice, the people with normal anatomy and lots of symptoms tend to be the ones who get the most trouble afterwards with the dysphagia and gas bloat syndrome. What's happening with that and the endoluminal therapies?
I think that the side effects, especially with dysphagia and gas bloat, are significantly decreased without a total fundoplication. So for Strata, it's actually uncommon to have significant dysphagia and very uncommon for gas bloat. Or transoral fundoplication, I don't have the exact numbers off the top of my head, but it's significantly less, certainly in my own experience and other people's experience, than compared to Nissen. But with that said, I tell everybody to expect dysphagia in the first month, liquid diet or semi-soft diet for a month, and expect some early dysphagia. I haven't seen anybody with long-term significant dysphagia following it, though. I think that's uncommon compared to a laparoscopic Nissen.
I like to just say, in regards to preoperative dysphagia, if someone has severe or moderate preoperative dysphagia, you really need to look behind the pathology here and make sure that there's nothing else, because otherwise you get in trouble with any procedure.
How about on the side there?
I would like to comment on stricture due to peptic esophagitis. when you dilate using a balloon or guide wire with bougie, it's some of the patient we could not pass the bougie on the guide wire. In those patients, you can pass the balloon easily, and you can dilate easily too. And most of the time we do not use fluoroscopy. We just pass the balloon and dilate 3 stage. It's easier, I think.
Thank you.
About the Strata procedure, we know that this technique has been, on the market since 2003, so if I'm not wrong, almost 10 years, and then went off the market, and now it's back again. I mean, what happened? We know that I think the company has some problems, and then if you look at the data, it seems pretty good results as you've shown, and then now it's back in the market again. I mean, what happened? And they are making the device better? They did any improvements? What's about Strata right now?
I know a lot about patient care and reflux, not so much about finances. So I think that played a role in the business management and the industry development. The device now is slightly new. The technology is newer, and the generator is newer and faster. The basic tenets of the treatment, radiofrequency energy, precisely controlled, delivered to the lower esophageal sphincter, is the same as it's always been. And there was a hiatus of time that the procedure was not available and the product was not available. So it is available now, and I think just like any other technology, it's evolved over time and it's a little bit better. And I would agree with you that it's been around for a long time and the data seems pretty good.
We'll take one last question on the side there.
I have a question regarding treatment of leaks after gastric bypass, gastrojejunectomy, anastomotic leaks with stenting. Do you have any restriction on selection criteria? In other words, post-op day 1, major leak, serous peritonitis, would you consider stenting it? And second question I have, how many of these that you stent will end up having some secondary procedures such as drainage of abscess, CT guided?
Let's have this question answered by Pipan and then by Brent Miedema.
Sure. So I think we've definitely evolved when we talk about bariatric management. I think the principles are still the same. I think it depends on the stability of your patient first. I think if they have generalized peritonitis, obviously you're going to be going to the operating room. Then I think it depends on the leak itself. If it's a controlled leak, meaning if there's a leak that you see radiographically and you have a surgical or a radiologic drain next to the leak, that's probably the first and most important thing. I think what the stent does for you, it first allows you to probably control the amount of contamination, and probably more importantly, allows you to start enteral feedings on that patient. That's probably the biggest thing. A lot of times we've tried to manage these leaks down the road. The chronic leaks are very hard to manage with stents. I think more and more we're trying to manage these acute leaks, what you've described, that patient immediately post-op after that first 7 days, but before 1 or 2 months out. I think that's probably going to be the best role for our stents. It's going to be very analogous to our biliary leaks, that maybe we'll be able to speed up the process of closure and avoid a lot of the contamination. But the most basic principles of surgery, you still have to abide by. You got to make sure you drain the other side. You got to make sure you do all those other things. That's my take on it right now.
Basically, for the acute leaks, there's very few contraindications. If it's contained, you just have to do the stent, or if you get a drain there that you placed at surgery. And most of the time in our patient population, we just had to place the stent. Now, some patients have more contamination, and then I think you should do the laparoscopic washout and drainage.
I have one question regarding bariatric endoscopic procedures for Dr. Mikami. What is your future? I mean, if you look at the endoscopic procedures, are there different devices out there in the future for different indications? One for low BMI and to treat diabetes, and the other one as a stage procedure to get the patient to a bypass safe or do a sleeve?
I feel the future of weight loss surgery in general is to try to make all patients less risky. Number one, even patients with BMIs in the 40s, why not make them a BMI in the 30s and then do the operation of choice? Some of these patients may not need an operation. Unfortunately, in the some trials, weight loss surgery is needed, but I think if I had diabetes and my BMI was 34, I would want an endoluminal procedure first to see if my type 2 diabetes would go away, before moving to any other operation. So we have a huge amount of patients between 28 and 34 or 35 that have type 2 diabetes that really don't have any hope except medical therapy. And I think this is where the field of endoluminal treatment is going to start.
And I would just echo, I think right now, I think Dean presented obviously a lot of different devices that are very early in their development. Right now, our biggest hurdle is actually the FDA. That's our biggest hurdle for a majority of our devices in regulatory. There is going to be a position statement white paper that's coming out from both ASMBS, ASGE, and AGA, and as well as SAGES that's going to help, I think, push forward a lot more of these endoluminal therapies in collaboration with the FDA and other regulatory.
I want to thank you all for your questions and our presenters. We need to move on with the next portion of the program.